So our next session that we are going to have is by Josie of Schlegel Research Institute of Aging. And Josie is the Vice President of the Schlegel University of Waterloo Research Institute of Aging and part of the Schlegel Center for Learning, Research, Innovation in Long-Term Care. And Josie is going to review the research they've done on the evaluation of behavioral support units in the Mississauga-Halton region. So welcome, Josie.
Thanks very much. Hi, everyone. We are the Behavioral Supports Ontario program. Is there anyone in this room that does not know a little bit about BSO? I think pretty well everyone has heard about BSO. It's a $40 million investment by the Ontario government in improving the system of care for persons with dementia and their caregivers, with a primary focus on long-term care, although some LHINs have also provided some supports in community. And some different LHINs have approached the BSO program differently with slightly different implementation models. And the Mississauga-Halton LHIN asked the Schlegel Research Institute for Aging to conduct an evaluation of their particular take on the BSO implementation. So this is some results of that evaluation. Oh, I can't go back, can I? And I just wanted to mention the evaluation team was a group effort. So we had folks from the Inter-RAI University of Waterloo involved because we used RAI MDS data for some of the evaluation. Loretta Hillier was a key evaluator here who did much of the qualitative work and the interviews and focus groups that we conducted. Two people from the LHIN were very involved, and their co-authors, Rob Lowe and Sean Wiley. And I want to just recognize Michelle Collins, who's here at the front here. Just raise your hand, Michelle. She's taken over the BSO portfolio as well as the long-term care portfolio for the Mississauga-Halton LHIN. And Rob Lowe and Sean Wiley have moved on to other areas. So I just wanted you to meet her. We also had a multi-stakeholder advisory committee that guided and supported the evaluation design and evaluation. We had 6 objectives, but I'm only going to talk to the first 3 today, and in fact, I may not even get to the third one, depending on how our time goes. I'll do what I can to give you highlights. There is a full report available. It's 151 pages long. I'm happy to share that with you, and there's also an executive summary, so if anyone's interested in that, I'm happy to share that. I'm not going to describe all the methods we used here, but it was a mixed methods approach. And we used RAI MDS data. We used some existing data that's being collected by the LHIN. We used case studies, and we used various surveys and interviews. Some measures were process measures, some measures were outcome measures, some were qualitative and some were quantitative. And what I'm showing here today is just a selection of some of the results that we found from this survey or from this evaluation. So the first objective, what were the key stakeholders' perceptions of the BSO model? And information for this objective came primarily from interviews with BSO staff, with long-term care management, with older adults and their family members, and from case studies. So the Mississauga-Halton BSO model had 4 key features, and I've listed them here, and we'll talk about each of these briefly in turn. So the first one is an embedded model. One of the features of the Mississauga-Halton implementation was that the BSO staff were embedded within long-term care and community settings, as contrasted with some LHINs who have created mobile teams. And so these specially trained personal support workers and practical nurses were hired for each of the 27 long-term care homes in Mississauga-Halton, and their roles included prevention of responsive behaviors, problem solving, complex cases, and doing assessments and care planning. And some of this these are just a couple of quotes that are representative of what we found to be very strong support for this embedded model in the Mississauga-Halton LHIN. So an advantage is because we still work on the floor, we coach and mentor, and they get to see how we apply what we teach them. So it's building capacity within the home. One of the major strengths with having them embedded is that they have more timely access to help when needed, and they need the help right now. So those are two of the many quotes that we got suggesting strong support in this LHIN for the embedded model. So our conclusion here is that the embedded model enhances quality of care, consistency of care, and capacity building within long-term care. And BSO resources, that is the staff that were hired, split their time between direct care and capacity building activities within their long-term care homes. A second feature is investment in upstream activities. Mississauga-Halton LHIN, in addition to the resources to long-term care, funded 3 additional psychogeriatric resource consultants in community settings, and they were to help integrate between the community and long-term care and to do education and training. They also hired 3 outreach counselors who were funded to support clients and family members in the community. And 4 community support workers, 1 in each adult day program, were also hired and funded to assist in transitions from home to adult day programs and from adult day programs into long-term care, and also to build capacity within these adult day programs to manage responsive behaviors. And here's a quote from one of our interviews that, again, it's representative of what we heard from many people. There's a strong sense that upstream investment helps people manage for longer in the community, thus delaying entry to long-term care and likely preventing crisis situations that may lead to a trip to the emergency room. There is a definite sense that more should be invested in these community-based resources. And Pete, it's not his real name, is a case example that illustrates this. So he's a 90-year-old with Alzheimer's and very limited vision. Changes in routine really agitated him, and he frequently lost his glasses, which created a lot of agitation because he couldn't see very well, and that would mean routine changes. So he needed very specific routines. He started in an adult day program, and the staff person there worked with the family to develop a care book for Pete, which is one of the skills that the staff learn in the training, using the BSO tools to identify triggers and then come up with strategies for those triggers. Pete, when it was time to move to long-term care, the care book went with him, and it helped the staff incredibly in the long-term care home to set up routines that worked for him, so that he was able to maintain many of the same routines in long-term care that they had established in the adult day program. So the conclusion here is that investment in upstream activities helps people live longer in the community and it eases transitions, and that more supports in the community and outreach to the community are needed. Another feature of the Mississauga-Halton model, as with all BSO programs in the province, I would say, is a focus on capacity building. Many educational opportunities were provided: PISAs, You First, general persuasive approaches, Montessori, just to name some of them. In our interviews and surveys, long-term care management, the BSO staff, and frontline staff all credit this education with building capacity to address behaviors. They talked about 3 main things that education did for them. It helped improve documentation so that underlying factors are identified and dealt with to prevent behavioral expressions. For example, catching UTIs earlier and treating them sooner. The development of a common language so people were communicating more effectively. And then learning more effective care strategies once those triggers are identified. Many people commented that more behaviors previously assumed to be normal are now being identified and addressed. And this actually had an interesting impact on line listings of the number of responsive behaviors in long-term care per day. We saw actually an increase in reported behaviors over time, but a lot of variability around that. So it looked to be an upward trend, but it's likely due to the fact that people are identifying behaviors and documenting them much better than before BSO. And again, here are some representative quotes. There's lots of investment up front, which is great. Education pays off for us. This is a frontline staff member saying this, because the more we understand their behavior, it's easier to work with them. And long-term care management, as they go to the ongoing educational workshops, they come back all excited with what they learned and get ideas from other homes with how to work with residents. And I will say one of the things I learned from Michelle just a week ago or so is one of the things the LIN is working on now is a mentoring program where the homes that are having great success with responsive behaviors are becoming mentors for the homes that are having more challenges. So this kind of mentoring seems to be really important and powerful for the frontline staff. So BSO has effectively enhanced knowledge and capacity. Within both the long-term care home and the adult day programs, I haven't showed you the data from the adult day programs, but it's very similar to what I showed for long-term care. Okay, the fourth feature I want to mention about the Mississauga-Halton model is the philosophy of all behaviors have meaning was a key feature. This was reinforced in all education, in all the coaching, and in all the mentoring. And common tools and vocabulary were developed, which supported an interdisciplinary approach to problem solving and care delivery. And so this is one of the quotes we heard in our interviews from a long-term care manager. We don't hear staff saying anymore, he's always like that. Nothing we can do. I've noticed a big enhancement of the critical thinking skills of the registered staff, and also the PCAs are doing a lot more figuring out what the meaning is. And that is probably the crux of the success of the BSO program, is this figuring out what the meaning is and the triggers are for behaviors and finding successful strategies to address those. This is from a family member. Since people accomplished finding out what upsets her and what makes her happy, she's been Haldol free. It's been 2 to 3 months since she's had a dose. Okay, the second evaluation objective is to identify the impacts of the BSO program. And the first outcome was an anticipation that embedding these supports in long-term care homes and in the community would decrease transfers to the emergency room. That was a key anticipated outcome. And this slide is transfers from the ED or to the ED from long-term care using data from the RIMDS at 2 time periods. Time 1 is before BSO was implemented, so that's the blue bars, and time 2 is after BSO implementation, the red bars. So the first set of bars is the percent of all long-term care residents who went to the emergency room in the last 90 days once. So it was one visit to the room. And you can see there was a significant decline in the visits after BSO was implemented as compared to before. The second set of bars is those who went to the ER 2 or more times in that 90-day period. And again, you see a decrease from 2.7% to 2.1%. So this is transfers to the ER from long-term care for all reasons, not just responsive behaviors. So BSO may not be solely responsible for this decline, but it seems to be a contributor on the basis of other data that related specifically to transfers due to behaviors. So we do have some other data that supports this, as well as examples from people who were interviewed that demonstrated these hospital aversions. Another anticipated outcome was decreased expression of responsive behavior. And again, for this, we turned to the RI-MDS data. We looked at the rate of change in resident outcomes at 2 time periods. So we looked at pattern of change pre-BSO for a 6-month period, July to December 2011, so before implementation, and on every long-term care resident in the LHIN. So the sample size is over 5,000 seniors. And then we did the same thing for the same time period 1 year later, July to December 2012, which was after the BSO implementation. And we looked at a number of scores on RI-MDS. The one I'll show here is the composite score called the Aggressive Behavior Scale, which includes a composite measure of instances of verbal abuse, physical abuse, resistance to care, and socially inappropriate behavior. We looked at the trends in this score before BSO and after. And the blue line is the before BSO, so you can see before BSO an upward trend, which is typical in a long-term care population, that acuity increases over time. And the after BSO, there's the red dotted line, we saw a decrease over time, which demonstrates, and it's a highly significant trend here because our sample size is so high, and it shows that BSO is helping to decrease aggressive behaviors in the face of what is an upward trend normally, which is why we did the analysis this way. We also looked at this for various levels of cognitive performance to see if it was affected by level of cognition. And you can see, even though the absolute numbers change, the trend line is exactly the same. So our conclusion for those 2 impacts is that BSO was associated with declines in ER transfers and also declines in responsive behaviors. I am going to have to skip over this objective in the interest of time. So but I would like to close on one point, and this is what is happening in the Mississauga-Halton LHIN since this report was submitted. A few decisions have been made and more are under development. The resources have been increased to the adult day programs by adding 2 more PSWs to the adult day programs. A 0.5 coordinator is, as I understand, planned but not in place yet. There are more education sessions being planned for BSO staff. There's more flexibility now in the long-term care for the mix of PSW to RPNs. At first it was a set formula, and now there's more flexibility to the unique features of each home. And we are working on a mentoring program across the long-term care homes. And the report continues to be referenced in decision-making around sustainability planning. So thanks for your attention.